Greetings and a warm welcome to everyone. I am Nang Himaki, the sign moderator from CLIRNET. It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, CLIRNET. It stands as one of the largest live digital continuing medical education platforms in India, providing a space for doctors to create and share medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Amitav Banerjee, sir. Sir has done MBBS, MD, postdoctoral epidemiology, medical majoring in Community Government Medical College, Jabalpur. Professor and Head Community Medicine at Dr. D.Y. Patil Medical College, Pune. I would like to take this opportunity to provide a brief overview of today's topic, lifestyle and health window of opportunity for primordial prevention. Without any further delay, sir, I would like to hand over this session to you. Kindly proceed with your talk. Over to you, sir.
Thank you so much. It's given me great pleasure to come on this platform and share my views. And you may be wondering why I have kept the background as pandemic. Because uh, I was following the pandemic, and I was following the pandemic as it evolved across the globe. And we were tabulating the data in our department. And what came to light was the pandemic exposed the fault line, firstly, in the public health infrastructure, adequacy of health services, particularly in developing countries like India. And it also exposed the fault lines in the population health. Population health, in the sense as measured by obesity or the overweight. So we had tabulated the data from 180 countries, and we found a uh, very marked correlation of obesity with excess deaths from the virus. So keeping that in focus, the purpose is to, we earlier used to teach our students that lifestyle, overweight, physical activity, they are important for prevention of non-communicable disease. After the pandemic, at least I have started teaching my students that they are equally important for protection from communicable viruses, communicable diseases, respiratory viruses like COVID or influenza, as the data indicates. And because communicable disease will kill you within 2 weeks, whereas non-communicable disease take decades to develop. So both ways, in the short term and in the long term, having a good lifestyle, physical activity, good nutrition can have a lot of health dividends. So I will be briefly going through these points. And another important thing, particularly for Asians and Indians, are that we are handicapped by earlier deprivation. That is, we had population have faced starvations. So we have got a genetic handicap. There's a hypothesis of thrifty gene that we cannot metabolize fat properly, we cannot metabolize carbohydrate properly, and we have a tendency to central obesity, visceral fat. And with the same BMI, at the same BMI, because of a fat distribution, we are at a greater risk of non-communicable disease compared to the Caucasians. So I'll be touching on that also. Another disadvantage, countries like India with a high rate of child malnutrition. More than 30% of our under fives have got various grades of malnutrition. And there is also during antenatal period, due to maternal malnutrition, there may be almost 20% to 25% of our newborns may be underweight, intrauterine growth retardation. And according to one hypothesis, this deprivation, intrauterine growth retardation or childhood deprivation, can program the humans to suffer from non-communicable disease like syndrome X or glucose intolerance or diabetes in later life. So these are the two disadvantages we have due to our thrifty gene and due to our high rate of childhood and intrauterine growth retardation. So we have a tendency to develop the non-communicable disease like diabetes or coronary artery diseases a decade or two earlier compared to our Caucasian counterparts. So these are some of the things. And of course, these are the genetic programming, which is called our destiny. But the positive side is that this is a genotype, but the phenotype, the manifestation of this disease can be averted by countering it with good lifestyle. So we have to make more
Excuse me, sir.
efforts. Yeah,
Sorry to interrupt in between, sir. You were sharing a PPT, sir.
yeah, I will be sharing. This is just an
Okay, okay,
introductory.
okay, okay.
So that's I'll just soon sharing it. So this is a window of opportunity. And another good thing is that I will just be showing some data of some countries where our overweight has yet not caught up with the Western countries. Asian and African countries are one third to half obese or overweight as compared to the Caucasians. And we will see from the data that their mortality from the COVID virus was 10 to 20 times higher compared to the Asian and African countries. So, but our middle class is fast catching up with the West. So this is called primordial prevention, that we have an opportunity that if we can restrict ourselves and not adopt the unhealthy lifestyles, particularly in the fast food, ultra processed food, and the sedentary lifestyle. We are developing into a laptop class. So this window of opportunity, if we can take advantage of, then we are prepared for future pandemic. So now I will be sharing some slides I just gave you an overview. So I'll be just sharing the slides. So how do I go to play? Can you see the slide? Is it visible?
No, sir.
Just a minute. I will. Yeah, now I think you will be able to see it. Is it okay?
Yes, sir.
Yeah, this is the like as I have already said that lifestyle factors are important. We have got a genetic handicap, intrauterine growth retardation, and these are, of course, as clinicians, you may be aware that these are the disorders related to lifestyle. That is obesity, diabetes, cardiovascular disorders, and others like osteoarthritis and even certain cancers. So, of course, cancers are there. Tobacco and alcohol is a risk factor for cancer. That also comes in lifestyle. So these are some of the factors. And as we know, we are fast becoming the diabetes capital of the world. Diabetic burden in India, as on today, is more than 100 million diabetics, and more than that, 136 million are pre-diabetics. So, and as I said, the Indians have got a genetic handicap due to deprivation in early life. And the global burden, the past 20 years, the cardiovascular disease has almost doubled. In 1990, if you see, it was 271 per million, and 2019, it is 523. Of course, population has aged, population has increased, but the health services are overburdened. And cardiovascular deaths also has increased, but not as much as the number of cases, because probably we are having better treatment modalities. So that's the encouraging thing. And the global disability adjusted life years, that is the life free from disability lost is doubled. I mean, people may be living, but the quality of life may have been compromised. So these are some of the statistics. So, and this figure shows us the burden of the lifestyle diseases as far as cardiovascular disease are concerned. More than 50% are the ischemic heart disease, that is in the blue color, and the one third are the stroke in the maroon, and the rest are other related to coronary artery diseases or cerebrovascular accidents, and rheumatic heart disease and endocarditis and myocarditis. And some of the, as I said, we have got a particular genotype, manifestation in the phenotype, and where we can, with our lifestyle, change the course of our programming. That is called modifiable risk factors. So many of them are like smoking is a major cause of cancers, and it's a major lifestyle factor. Dyslipidemia, cholesterol, particularly in middle age. At a higher age, it may have less effect. Hypertension is the number one risk factor. Diabetes in our country, we saw. Abdominal obesity, as Indians are predisposed. Psychosocial factors. Now, yoga, meditation, these are being followed by the Western experts also. Lack of these fruits and vegetables. Now we are going for the ultra processed foods, and fresh fruits and vegetables, at least 5 helpings, 70 grams each, is supposed to be good protective for more risk factors. And alcohol consumption alcohol also is related to many non-communicable and as well as communicable diseases by lowering the immunity. And lack of regular physical activity. Most of our jobs are becoming sedentary. Long hours on the computer, most of them are doing desk jobs. So all these are promoting it. And as I said, Indians are having a genetic handicap. This is a YY paradox. This is not a YY is not any gene. It is the Y on the right side is Dr. Yagnik, and Y on the left side is Dr. Yudkin. One is a Caucasian and one is an Indian. This is a picture 20 years ago. Dr. Chitranjan Yagnik from Pune has done a lot of work on this. Both are having the same Y surname, starting with Y, and both are having the same BMI, 22.3, 22.3, both are having. But if you see the bottom, that is the body fat distribution, there is a marked difference. The Caucasian is having 9.1% body fat and the Indian is having 21.2%. So we have to see this as a clinician, that BMI can be misleading for Asian and Indians, because that may be the reason why we get the coronary events or diabetes a decade or two earlier. So some experts suggest that the cutoff for overweight for Asians should be 23 rather than 25 as it is today. So this has to be kept in mind. So these are the risk factors, more or less they have remained stable, except for the high body mass index has come from number 6 to number 5 on the right side rank. And air pollution is always there. Air pollution is number 4, and tobacco has gone down a little. So there is only one change in the ranking. The biggest risk factor is high blood pressure, because we know the rule of halves. 50% of blood pressure do not get treated, 50% do not get detected, and 50% do not comply. So high blood pressure, then dietary risk. Dietary risk is number 2, and perhaps it may overtake hypertension also. And cholesterol is number 3, number 4 air pollution, and tobacco was number 5, it has become number 6. And then of course other things are there: kidney function, alcohol use, sedentary lifestyle, less physical activity. Actually all those are cumulative. Ranking does not give you much of a indication, because if you are having low physical activity, you are more likely to get hypertension, you are more likely to get diabetes. So whatever is number 1 may have been contributed by the factors which are lower down the list. So these are, they interact, they are catalytic, they are synergistic. So these factors are, ranking does not give the true picture. Obesity and cardiovascular fitness, the studies are there which shows that more harmful is inactivity, even more harmful than even compared to obesity. So obesity, of course, reduction of obesity is very desirable, as we will see subsequently. But even a obese person, if the person can do a physical activity within limits, that person lowers the risk of coronary events and cerebrovascular events. Obese at 20, overweight and obese fit had 25% and 40% increased mortality, overweight and obese fit. For patients who are both unfit and obese, the hazard ratio is 3 times. 3 times they are more likely. Patients who are fit but obese, it is 1.4 times. So who are both unfit and obese, it doubles. The study showed patients who have low cardiovascular normal weight, the hazard ratio was 2.18. So cardiovascular fitness is more important. And for that, brisk walking, 30 minutes at least per day is the minimum, or jogging or swimming, depending on the capacity of the person. One should not overexert also. There are so many cases of sudden cardiac events, so one has to be careful. But French paradox, so we are having these risk factors, but there may be some racial factors, some other social factors which may modify this impact of these risk factors. The French paradox shows that they have got very low coronary heart disease despite high intake of dietary cholesterol and saturated fat. And similarly, Israel, they are not having a high cholesterol or fat diet, but still they have got a higher coronary events. So there have to be local studies. That hypothesis, saturated fat and coronary heart disease heart hypothesis, is under a lot of questions nowadays. So there may be some racial differences. Another thing they show, there are certain mitigating factors like social networks, psychological health, social health, which can, in spite of a unhealthy lifestyle, even that social activity is also a lifestyle, in fact. So people are becoming more isolated, particularly with the laptop class from children. They are using mobiles. So there is interpersonal communications, relations, family, community. So these may be another thing which we may consider. More research is required. New culprit now, earlier it was the fat hypothesis, as I said. Nowadays the studies indicate that sugar is a bigger culprit than even fat, because sugar has a high glycemic index and the sudden spike, and it is known as the silent killer. And similarly, the sitting and sugar are the major culprits as on today. Studies done by Morris, who studied in the 60s, bus conductors and bus drivers, they found the bus drivers had twice the number of heart attacks than conductors, then double deckers. Conductors used to go up and down. Those were the pairing studies. Similarly, he did studies in postal workers, the postal clerks and the postmen. In 20 years back, the postman had to go cycle to deliver the letters. He found that postal clerks who were sedentary are having more cardiac events compared to the postmen. So nowadays, everybody is working on the desk. So now that's one reason, like we have to, then of course there are certain concerns about the myocarditis and all young. So that requires again research, because everything we have a tendency to attribute to lifestyle. But if we have the population level data, particularly in European countries, Australia, New Zealand, there are certain concerns that cardiac, particularly myocarditis, young people have increased. So that we have to keep in mind. Of course, that is not related to lifestyle. So that, but as a causative research. So these are some of the relative risk and the population attributable. Relative risk is at the individual level. If an individual come to me, it's all-cause mortality and relative risk, say, cardiovascular disease, all-cause mortality of physical inactivity. This is about relative risk. A person is physically inactive at the individual, he's got 1.28 times more than the person who is physically active. But at the population, it translates into 7. So in public health, we have to see the population attributed risk, because if a large number of people are inactive, and as the conditions are becoming like that, so at the individual level, it becomes cumulative to a large burden on the health services. Similarly to the SARS COVID pandemic, individual risk was very less, 0.1. But since large number were affected, the hospital services got overwhelmed. So similarly for non-communicable disease, so if you see the population risk translates for cardiovascular, it's almost 7 times, 6 to 7 times. Coronary heart attack, 5 times. Relative risk is at the individual level, but the population, large number of people inactive. So that is why we have the population approach to prevention. We make a culture of physical activity, we make a culture of healthy food, and hypertension also. Hypertension, of course, is a marginal. Type 2 diabetes 4 times. So these are the benefits. At the population level, it is more pronounced than at the individual level. Now, another thing which is coming up is the pharmacological solutions for the lifestyle disorders, fast solutions. There is a paper in New England Journal of Medicine just a few months back where polypills are coming up, which contains a combination of, say, statins and aspirin and some antihypertension and some. So, attractive hai because it is a passive statins, antihypertension medication, and aspirin. So these are going to be $1 billion market, but as a clinician, one has to weigh the risk benefit and patient education. The pill is a quick solution, but for every pill, there can be a ill following the pill. So we have to give a thought to it, whether lifestyle is sustained or whether we have pharmacological solutions. Weight reduction, this weight loss pills are also coming. It's again going to be $1 billion market. So again, it requires patient education and the cost benefit. Some cases, selected cases may be required, like bariatric surgery, but across the board, one has to consider. So these are some of the, some celebrities also have reduced weight, lifestyle modification and physical activity. Then in this pandemic, as I was saying, why I keep saying window of opportunity. So of course, these people and with comorbidities, so they were more vulnerable, as we will see 10 to 20 times more in the Western countries where these conditions are more common and people are elderly. And we also saw more than the age, the obesity was a major killer during the pandemic. This is, as I was saying, we plotted 180 countries, the age and the BMI, and tabulated the deaths per million. And if you see a 3-dimensional figure with the help of ICER Pune, we plotted this from 180 countries. So right side and anterior side of the cube, there is a clustering which coincides with the overweight and the overage. And we will see subsequently from this 180 countries, some illustrative countries I have selected to just indicate. So, and similarly, we found a paper that obesity in COVID-19 in systematic review, they increased the death from and hospitalization from COVID 2 to 3 times more than a non-obese person. So this is a window of opportunity for future pandemics, because we can expect pandemic, as they say, disease X and other things we cannot. But if we cannot know which virus, but if we increase the host resistance by controlling obesity, or mortality will be minimum. So this is, I am just illustrating a very few countries, which gives the idea how much obesity affects the mortality from COVID-19. The first column is the country, second column is the death at the start of the pandemic, May 2020, and second is 2 years into the pandemic, February 2022. If you see the Western countries on top, USA, UK, Sweden, Brazil. Brazil has just 10 to start with, but in 2 years, it overcrossed the other USA and all, because if you see the median age of Brazil is low, 33, but it has got a obesity almost 60, overweight, 57.3. So, and though vaccination coverage was higher in the Western countries like USA, UK, Sweden, their vaccination was 60-70%. And if you see the African and Asian countries, the lowest vaccination was in the African countries, 3%, 6%, most of the African countries. South Africa had the highest vaccination, about 30%. But in the African countries, the mortality after 2 years, if you see, was in 4 digits in South Africa, because overweight was 53 compared to other African is 17 or 27 overweight person, 26. And if you see, very illustrative is Japan. Japan had the oldest age. If you see the fourth column, median years is 48 compared to 30, 40 in even the developed countries. So Japan is the highest longevity. But if you see the fifth column, second last column, Japan had a overweight percentage of only 24 compared to 67 in USA. And its mortality was in 3 digits compared to 4 digits in USA, UK, Sweden, and even Brazil. So this Brazil and Japan emphasizes that more than the age, because Brazil has a younger population, 33 median, but overweight is almost touching 60. And Japan has got a highest age, 48, very old people, but they are very healthy, lean, 24. So that indicates that. So this is the window of opportunity, or middle class is fast going to the Western lifestyle. So this is the first wave. It hit the slums. We had very little casualties because they were lean. They were maybe younger also. Then the second wave, we have comparative higher casualties because they were the sedentary people, obese people. So we had a lesson in our country also, and these are the people who are fast catching up in obesity and sedentary. So, and we also carried out a study that younger generation also have a deficiency of vitamin D. Vitamin D also lowers the immunity. Vaccine response also reduces, and the immunity to viral infection also reduces. Diabetes also we found 10% in the rural areas also, and most were unaware. Risk factors were also found in the rural areas in our field practice area. So these are the lifestyle we are moving towards. Earlier we used to go on cycles, we used to get physical activity, vitamin D. Now we are motorized, youngsters in school, colleges, so they are not having the exercise, now the vitamin D. Workplace were open, now we have crowded workplaces. This was a Japanese diet, healthy diet. We saw they are the longest lived and the least mortality, lean. And this is now we are going for the American fast food. So this is primordial prevention. If we can avoid this, which is again very difficult, the market forces are very strong. Food industry is very strong. So is the pharma industry. The food industry will promote the fast food, and the pharma industry will provide the solutions. So both are working in tandem. So this is a change over the year. In lockdown also increased the obesity. So the way forward, increase in health budget, public health facilities. This is a long term. Promote healthy food habits. Avoid sugar and soft drinks, particularly fast foods. Encourage physical activity. Enabling environment. We can't walk on the streets. Pedestrians are knocked down. Cyclists are knocked down. We don't have cycle tracks. So this environment is required. So if you know the enemy, know yourself. You need not the result of 100 battles. That is, if you know which factor is killing us. We found that obesity is killing us. Unhealthy lifestyle is killing us from viruses. We need not worry of 100 viruses. But if you not the enemy, if you know yourself, but not the enemy, for every victory gained, you will also suffer a defeat. If you know neither the enemy nor yourself, you will succumb in every battle. So these are the data which is showing that we are going towards obesity. We are going towards unhealthy lifestyle. So we are vulnerable to future pandemics. Unfortunately, nobody is talking about these things. They are talking of pharmacological solution, including vaccines. They are additional measures. But the core measure are the lifestyle, because vaccines are every day new virus will come, new mutation will come. So that is additional measure. But this is and even the father of medicine also mentioned it. So consider whenever Hippocrates on airs, waters, and places in his almost 2000 years back, consider the season and what are the health implications of winds, the hot and the cold, the quality of water, and of course these are the nutrition, these are the safe water environment. And the last two lines are important. Whether inhabitants are given to excess and passivity, that is unhealthy fast food and passivity, or to physical labor. Think these things one ought to consider most attentively. So this Hippocrates or father had said, it is applicable perhaps more today than it was earlier, because earlier people had to hunt, people had to work. Now what Hippocrates said 2000 500 years ago are more accurate today when we have choice to be passive. Earlier days, we never had this choice. These are some of the references, and these are some of the studies we carried out. Thank you. I have finished. If can any questions, I can take.
Thank you so much, sir, for your comprehensive talk. The content was highly informative. So, sir, we have received a few questions from our participating doctors. So, may I have your permission to present them?
Yeah, definitely.
Okay, sir. Just give me a moment. So, this is the first question, sir. So, let me know once you are done with your first question.
Yeah, this is the major challenges. Actually, one of the most difficult to overcome is the marketing, social marketing by the food industry and automobile industry, of course. And they catch the most of the advertisements are directed at children, and many of the food items have high sugar content which are addictive. Most of the soft drinks have got caffeine content which are again addictive. So there are challenges, marketing challenges, because we recently did a study among school children how they perceive the advertisements, and many times most of these processed products are promoted as health foods. So these are major challenges, and it requires some policy decisions at the policymaker level, and having healthy food in the canteens, healthy like tobacco. They are not allowing sale of tobacco within 1 or 2 kilometers of educational institutions. So challenges are many, and of course challenges are the social changes also. We have got more working mothers, we have got more working parents, and they order Zomato, and very easily temptation is there to order fast food. So these are some of the challenges. Primordial prevention is very difficult actually until unless the society is totally isolated in a remote island, which is not there. So we have to educate the doctors are in a position to educate the patients about lifestyle. But again, doctors are also busy, so that is again a challenge. Yeah, challenges are theory. It is easy, but it is difficult. But this is the way forward. Yeah, workplace and education institution definitely. As I said, school canteens, then school teachers. We can educate the school teachers on healthy nutrition. And children are the very important because their lifelong habits are formed. Similarly, the workplaces, because most workplaces have canteens where they have got subsidized. So if the employers are educated, they will only promote healthy food, and they will disallow ultra processed packets and ultra processed foods. And there can be some educational activities in workplace or in education institutions. We have got nutrition weeks, we have got some recipes, and because India is a multicultural country, so all the cultures have all the different regions of India have got different food habits, and they can exchange the healthy food, and they can promote some competition, and other things can be there, healthy food competition and other things. Primordial prevention, the fast growing, the specific population and demographics that may benefit most from primordial prevention. We are at a crucial juncture, India. Like Brazil is also a fast developing economy, and those people who become rich fast, they adopt the habits of sedentary habits. They adopt sedentary habits. They adopt fast foods. They adopt sugary drinks. And Brazil is one example where the obesity is almost touching the overweight is touching the Western rates. Indian middle class is fast catching up. So this middle class education as on today, and not only middle class, we have even the newly rich, we have seen in the urban area, the suburbs of big cities or population we did. They also emulate the affluence and marketing. The marketing is targeted there. And like in the Western countries, the blue collar workers are now more prone to cardiovascular disease because they are less aware. Whereas those who are more aware, they are those who have not more educated or aware, they go to gym, they take healthy diet, but the newly rich demographies. So India as a country is fast becoming rich, and new rich people who are climbing up the social ladder, climbing up the economic ladder, they will benefit the most. That is primordial prevention. Yeah, healthcare professionals are in a very advantageous position, but unfortunately, most of our doctors are overworked. So we can have counselors, like we have psychological counselors, we can have nutritional counselors who can complement the guidance, nutritional guidance. And of course, now most of the endocrinologists, most of these diabetic centers are definitely educating their patients on the importance of diet, intermittent fasting, diet, sedentary. So I think they are doing a good job. But as I said, the people who are becoming rich, who may not have access to proper medical practitioners, they may be more vulnerable. Yeah, digital health is a two-way thing. Uh, like technology, digital health tools be leveraged to enhance primordial prevention because it's a catch-22. The person who uses a digital technology, a smartphone or internet, yeah, they are already aware. So most of them, if you find, they are aware of the primordial prevention. But it is the, as I said, people who have got surplus income, disposable income, but not very educated. Now everybody is growing economy. So it may not reach those people. But the other marketing may reach because they have got multiple ways to reach the consumer. They do market research. And that is one disadvantage. And digital health tools, other disadvantage like person to person, the communication is better. And but digital health, you are just giving information, but a doctor talks, and doctor by his or her own lifestyle acts as a role model, or a teacher for that matter. You don't require a doctor because school children are also getting obese. So teacher education may have a better impact than a digital. But digital tool do have other ways, like you have got if a person is exercising, he or she can see how many calories he or she has burned and that type of thing. But that can be, but primarily it is person to person communication.
Thank you, sir, for addressing all the inquiries from the doctors. I extend my gratitude to all the participating doctors of your consistent engagement on our platform. Once again, thank you so much, sir, for your generous contributing for your valuable time and insights on our platform. With everyone's approval, can we bring the session to a conclusion?
Thank you. Thank you.
Okay.
It was
Thank you
a
so much, sir.
pleasure. Thank you.
Thank you.
Thank you.